So good afternoon, everyone. Today I will be presenting the grand rounds for endocrinology, and I'll be talking to you about type 3C diabetes, updating it. I think I presented maybe about 7 or 8 years ago. And I have no conflicts to declare for this particular presentation. So the things that I will be going over is what is type 3C diabetes, how common is it, what is the interaction between the endocrine and exocrine pancreas, potential mechanisms of islet dysfunction in exocrine pancreatic disease, and then the clinical features and some aspects of management of type 3C diabetes. So obviously, type 3C is one of the subtypes of diabetes, and goes back to the classification of diabetes as to what types of diabetes are there. So, being from India, we always have this thing about how a few thousand years ago, people described excess amount of sugar in the urine, and actually, one of the famous Ayurvedic physicians and a surgeon, actually, he was one of the persons who developed the skin flap technique for operating on the face, named Sushruta. And this picture was actually recently taken by me because it was, I had been to my medical school in December, and this had been recently installed in the lecture hall complex of our medical school, a statue of Sushruta. And he had described two types of diabetes: people who were lean and people who were obese. So which kind of analogous to the type 1 and type 2 diabetes that we currently talk about. Now, the current approach to the classification of diabetes is supposed to be an etiologic classification. The first attempt, the National Diabetes Data Group in 1979 was the first to come up with a classification, which was subsequently adopted by the WHO. And since then, there have been different versions of this. And one of the main reasons for this change has been, as we understand the disease better, we have, refined what we think is the actual etiology of specific types of diabetes. So the approach has always been to try and classify it on an etiologic basis, with the eventual aim that, by defining it correctly, we will be able to treat the complications appropriately and also find specific causes for which there may be treatments. So in 2003 is when the ADA published this table. So when you look at this is every year in January, even now January 2024, we get this supplement from the American Diabetes Association, if you're a member, and it's a supplement to diabetes care, and it has standards of care for type of diabetes 25 a year. So even this year we have one which is the latest version. So in 2003, when they published this, they came up with this table. And as you can see here, they wrote this etiologic classification, and they said there was, one was type 1 diabetes, immune A and B, which was immune mediated and idiopathic. The second was type 2 diabetes. And then the third was other specific types. And under that, there was A, which was genetic defects of cell function. Then there was genetic defects of insulin action. And then C was disease of the exocrine pancreas. And under which, so that is the reason why this was actually called type 3C diabetes, diabetes associated with exocrine pancreatic disease. So later on, I mean, we no longer get this table. We actually, since 2016 or so, this table is not there. When you look up the current classification, so they changed the 3 from Roman numerals to Arabic numerals because that's what we commonly use nowadays. So it was changed to type 3C, and the C is a lowercase c, not an uppercase C. So that is what it has been used. It also goes by other terms such as pancreatogenic diabetes, diabetes of the exocrine pancreas, pancreatic diabetes, diabetes secondary to pancreatic disease. So if you go on EPIC and you want to code for type 2C diabetes, you may have trouble. In some versions, it is there. In some other versions, you'll have to put it as diabetes secondary to pancreatic disease. So you may have, so some versions have it, some versions don't. Although it is included, if you go through the ICD-9, ICD-10, you can still get that. It's a bit more complicated on how exactly you code it, but that is how it has been classified. So how do we diagnose it? There is no universally accepted criteria for the diagnosis of type 3C diabetes. So it should have a diagnosis of diabetes. It should have a diagnosis of pancreatic disease and a reasonable certainty that the diabetes is due to pancreatic disease. So that is how we commonly use it. There was a definition that was offered, and in the initial studies, people actually used this definition, where Ewald and Bretzel, they had offered these criteria. They had major criteria: exocrine pancreatic insufficiency by monoclonal fecal elastase testing or direct function tests, consistent pancreatic abnormalities on imaging, either endoscopy, ultrasound, MRI, or CT scan, and absence of any markers of autoimmune type 1 diabetes. So those 3 had to be present. And there were some minor criteria, including impaired beta cell function. They had to use either a HOMA B cell function or a C-peptide or glucose concentration, absence of insulin resistance, impaired incretin secretion, and low concentrations of lipid-soluble vitamins. So these were the minor criteria. So many of the studies that have been done in type 3C diabetes have used some of these criteria, but from a clinical point, we actually just follow the one that I said before: diagnosis of diabetes, there's pancreatic disease, and we think that the 2 are, that the diabetes is caused by pancreatic disease. So that there's a reasonable certainty of that. So that's what we are using. So that is how the disease has been defined. As far as the current classification itself is concerned, as I said, it is mainly into type 1 and type 2 diabetes, and then you get other diabetes. So this is the, if you go to the latest version, this is what it'll say. What is the current classification? It'll give you type 1, then it'll give you type 2. Then you have monogenic diabetes, gestational diabetes, other diseases associated with, and you'll have all these disorders. And then you have drug-associated diabetes. So that is the current classification. So if you're looking for this in the main ADA classification of diabetes, you will not find type 3C diabetes. So you can, either call it diabetes associated with pancreatic disease or diabetes with, of the exocrine pancreas. So how common is it, and what exactly, what do we know about its prevalence and incidence? Now, this again, because the definition is not very clear, a lot of the times when people go in and look at trying to look at the epidemiology of disease, they go through medical records, hospital admissions, things like that. One of the problems is that most of the time, this will either be diagnosed as type 2 or type 1. If they are on insulin, or if they have, they're lean on insulin, a lot of the times the admitting physicians will say insulin-dependent diabetes or type 1 diabetes, or they'll say if they're, if it's mild, they'll put them as type 2 diabetes. So there is a underreporting of the diagnosis of pancreatic diabetes. And this was a study that was conducted in United Kingdom, in England. So they looked at the primary records. So this is between 2015 and 2016. And they looked at the diabetes classification, glycemic control in those with and without pancreatic disease. And so what did they find? So this is the general outline. So what you can see here is that so there are two types of classifications here in terms of chronic pancreatitis and also acute pancreatitis. So those who had a history of acute pancreatitis and then diabetes, and then the chronic pancreatitis. And so you can see here that actually the number of individuals with diabetes following acute pancreatitis is actually a bit higher than the number of people with chronic pancreatitis. So this is something that we often forget, in the sense that most of the time when we are talking about type 3 pancreatic diabetes, we're talking about chronic pancreatitis rather than acute pancreatitis. So this actually, even in many of the studies that have been done in this, they have focused on chronic pancreatitis rather than acute pancreatitis. However, when you look at this, this is the, in the same study, when they looked at what happens to these individuals over time, you can see that, this is just looking at how many of them will go on insulin over time. And for those with type 2 diabetes, this is over the next 5-6 years that, you only have about 6% or 7% going on insulin in that period of time. Whereas for those with acute pancreatitis, it's about 21%. And for those with chronic pancreatitis, it's about 60% who will be going on to require insulin. So these figures are given here. So, so you will see that there is a much greater percentage of individuals who actually will need insulin within 5 years of an episode of pancreatitis than those who don't have pancreatitis, or just type 2 diabetes. So this is kind of an underestimated problem with acute pancreatitis. But again, if you look at the reviews that are there, you will see here the majority of patients that you have are type 2 diabetes. And then this is from, of the 1,868 participating with diabetes, 23% with type 1 diabetes, and then you have about 9% with type 3C. The incidence-wise, type 3C is more common than type 1, but because type 3C includes many people who with short survival, either because they had pancreatic cancer or because chronic pancreatitis and its the various causes of it do have a higher mortality unrelated, that could be unrelated to diabetes. The prevalence is not that much and is not as high as that of type 1, although the most recent data would say that the second most prevalent diabetes is probably type 3C rather than type 1 diabetes. So within this diagnosis of type 1, you have pancreatitis. Chronic pancreatitis is the most common. And then you have a different set of diagnoses that included hemochromatosis, pancreatic cancer, then you have pancreatectomy, and cystic fibrosis related to diabetes. So those are the different ones. Again, the pancreatitis group includes both acute and chronic pancreatitis. This is another study which again shows similar distributions here, 8% and 12% for type 3C diabetes and type 1 diabetes, and the majority again is type 2 diabetes, and similar distribution in terms of the cause, what the causes of these are. So we'll just review some of these and see what actually happens in these types of diabetes. So within the classification of type 3C diabetes, the main mechanisms are congenital or acquired absence or complete absence of islets, which is either pancreatic agenesis or pancreatectomy. So some people have argued that total pancreatectomy should be a separate entity by itself, the diabetes due to total pancreatectomy, because pathophysiologically it has more things wrong with it than just any of these other types of pancreatic diabetes. Part of it is related to the absence of complete absence of both endocrine and exocrine function, and also because when you have total pancreatectomy, you have a change in the GI anatomy, which causes multiple defects. Like most of them would have, partial gastrectomy, gastroesophageal bypass. The whole procedure that involves total pancreatectomy would require a different approach to it than typical just pancreatic diabetes. Then you have chronic pancreatitis, pancreatectomy partial, and then you have severe acute pancreatitis, cystic fibrosis, hemochromatosis. Then we'll talk about the paraneoplastic, that is the pancreatic ductal adenocarcinoma. And then you have transient hyperglycemia of acute pancreatitis. So these are the different types of disease processes that you have. So when you look at acute pancreatitis, this is actually less studied than the chronic pancreatitis. Part of it being because it is, at least at its onset, there is an overwhelming emphasis on the pancreatitis itself because it's a painful disease. Management is focused on pancreatitis, and then many of them are not followed up. Okay, so that's one of the problems. There are approximately 275,000 admissions for acute pancreatitis in the United States, and costs about $2.5 billion. And one of the lesser recognized consequences is this endocrine and exocrine deficiency related to that. So this one here in this study, you can see here, at 3 months, you have about 3% developing diabetes. At 12 months, about 7%, 18 months, 9%, and at 24 months, you have 11% of patients who have had a single episode of acute pancreatitis have becoming diabetic. So there is certainly a growing concern about not following patients with a single episode of diabetes, of pancreatitis for glycemic control. So when you look at this, you have, there are 3 things here. One is that you have stress hyperglycemia. So that is what we call the transient hyperglycemia of acute pancreatitis. Then you have unrecognized diabetes, which basically means that they had diabetes before, and they, when you do their A1C on admission, it is a bit high. So either they are pre-diabetic or diabetic at the time of admission. And then, of course, there is a totally new onset diabetes after pancreatitis. So whenever we see someone with pancreatitis, it's important to recognize that this can happen and follow them up appropriately. So just to emphasize, this is one of the studies which was published just this month in Pancreas online, and it was they wanted to look at the new onset diabetes after necrotizing pancreatitis. So the more severe the pancreatitis, the more likely that you're going to have. So even though it's a single episode, so they looked at patients with severe necrotizing pancreatitis. They looked at more than 90 days after their acute pancreatitis, and then there were 390 eligible patients, mostly men, 66%. They were 59 years. They were older in terms of their ages compared to other patients. And new onset diabetes was 26% after a median of 216 days. Of the new onset diabetes, 84% required insulin, 69% developed exocrine pancreatic insufficiency. And the odds ratio, age, male sex, obesity, presence of exocrine pancreatic insufficiency, diffuse pancreatic necrosis were the predictors of development of pancreatic diabetes. So in their modeling, they also found that abdominal fat on CT and visceral fat area was an independent predictor. So one of the things that we find both in this study and also in the chronic pancreatitis predict T3 study is that some of the risk factors for diabetes, for type 2 diabetes, are also the risk factors for developing type 3C diabetes. That means people who were obese, who had features of the metabolic syndrome, more visceral fat, those were the ones who were developing type 3C diabetes. And then there's the second component, which is the severity of the pancreatitis itself. So those are two things that you have to take into consideration. So that means about 1 in 4 patients with pancreatitis will go on to develop permanent diabetes. So this is something that we have to keep in mind. So one of the recommendation is that this is what we should do after you have, somebody has an episode of acute pancreatitis. So, obviously, if their A1C is already high, they should be treated as prediabetes or diabetes. If they're not, then additional testing should be done at 3 months after hospital discharge, obtain A1C and LGTT, and then, after that, decide on what you have to do. So they are at high risk for future development of diabetes, and for that reason, they need to be screened annually, irrespective of their age. If their blood sugars are high, we still want to rule out type 1 diabetes, especially because they have a high rate of insulin requirement. So we want to make sure that they're not type 1. So do the islet antibodies, and then obtain a C-peptide level, and then we classify them according to this as to what type of diabetes they might have. So now, before I go to the chronic pancreatitis and the other types of diabetes, I just wanted to go over the interaction between the exocrine and the endocrine pancreas. So one of the interesting things about the pancreatic islets, because they are endocrine cells, and unlike other endocrine cells, they're not in an organ. They're not in a specific, like you have a pituitary, you have thyroid, you have parathyroid, adrenals, gonads. They all are specific, endocrine secreting glands. Whereas here, the endocrine secreting cells are kind of distributed throughout another organ, which is the pancreas. So why are they why are the islets in the pancreas? And does it have any role? And one of the things that you will see is that there are interactions between these, and also some of the risk factor. There is a common risk factor for developing exocrine and endocrine pancreatic disease. So those things are important. So we really don't know exactly why they are there. Of course, the origin of the pancreatic islets is from ductal cells, and but as you know, the thyroid or the pituitary, they're also coming from different. They don't, it's not like the thyroid is staying in the mouth or in the pituitary is in the nose. They become separate organs by themselves. So here you have. So one of the theories behind it is the architecture of the pancreas, and you have these different lobes. I mean, under the microscope, there's some lobular architecture, and then you have the exocrine, pancreas, and the ductal, the pancreatic ducts, and then you have the islets that are interspersed between them. So one argument has been that one of the reasons is that by arranging these in this form, they actually get more blood supply, in the pancreas. Probably about 20% of the total pancreatic blood supply goes to the islets. even though it constitutes about 1 to 2% of the total mass of the pancreas. So by distributing them throughout the pancreas, you actually increase the surface area that it is exposed to, so that since the islet is designed to very quickly respond to changes in nutrients such as glucose, that having this higher surface area will improve the interaction between them. So one of the areas there is about, okay, how does the blood supply work? And so it is the blood supply of the endocrine and exocrine pancreas are interesting because there is a complex circulatory system which is both typical like any other organ, but also there is a portal circulation, both intra and within the islet itself, and also between the endocrine and exocrine pancreas. So, so if you go and look at it, you will see that many of the textbooks, for those interested in islet blood flow, we will see that there is each of the islets has an arteriole, and then the blood goes into it to the center, and then it distributes out, and then from there it drains, and how the drainage occurs into the pancreatic ducts. So this is the typical thing where you have an interaction between the endocrine and the exocrine cells. So for a long time, it was our belief that this is kind of still a unidirectional flow, that the blood flow is occurring from the islets into the pancreatic exocrine cells, to the ducts. Also within the islet, that there is only one direction by which the blood flows. So there is a central arteriole, and then the blood goes in, and you have this. However, just this month, there's a very nice review article on the dialogue between endocrine and exocrine pancreas. And there they have looked at this differently, and they have this model. And this is really based on advances in technology of how we can look at islets and how we can look at the pancreas as a whole, three-dimensional structures, and be able to look at blood flow dynamically. And what you find is that not all islets have an arteriole. In fact, there's a significant portion of the islets that don't have an arteriole, that there are capillary networks that are kind of distributed throughout. And also that there is bidirectional flow. So you can see that the blood flow can not only go from the islet towards the ductal cells, but from the ductal cells to the islets. So this interaction might actually be very helpful in kind of coordinating the function of both the exocrine and endocrine pancreas. So this concept will, in this, it helps maintain the islet microenvironment so that the maximum benefit in terms of its primary role as a regulator of nutrition, metabolism. So that's the newer understanding of how these might work, and which may also be why some of the diseases of the exocrine pancreas affect endocrine cells, and also how long-standing diabetes with impaired islet function causes exocrine pancreatic dysfunction. So you have what we call diabetic pancreatopathy. So you actually get exocrine disease of the pancreas in people with type 1 diabetes, not because there was pancreatitis, but because islet function, as it declines, it affects how the exocrine pancreas will function. So this one here shows you, how the islet, how the pancreatic, islets are, and how they are kind of budding off of these ductal, structures. So they are embedded within this, system of pancreatic acini, and here are the ducts. So one of the things that happens when you have exocrine pancreatic disease, most commonly, is ductal obstruction. You know? And that is one of the primary things that leads to some of the problems that occur subsequently, which also leads to inflammation surrounding the islets, which all of which will affect the dysfunction of the islets. So you can see here that this is the healthy SNI. Patients with diabetes will actually have diseased SNI, and which causes an increase in beta cell apoptosis. And the metabolic stresses that cause dysfunction here are pretty much the same that we also attribute to insulin resistance, such as fatty liver disease, obesity, and sarcopenia. All of these tend to affect the function of the SNI, which in turn can affect the function of the pancreatic islets. So one of the ways that we were surprised, when I worked in the lab, was that if you take an islet and put it in the pancreas, it actually works better than any other place you can put it. So you can see here that you can put 600 islets into the pancreas. In contrast, you need 3,200 to actually prevent them from becoming diabetic. And these are STZ rats. So and it's also true in the dogs and also in the pig model. So in all of those, what we find is that if you put the islets into the pancreas, they function better than wherever else you want to put them. So this again supports the hypothesis that there is something that is important in this interaction. So one of the models that people have used is actually cystic fibrosis diabetes. The reason why they have used it is because, unlike acute pancreatitis, there are some types of congenital pancreatitis, diseases and genetic types of pancreatitis. But even there, you already have an episode of pancreatitis before you even look at any of these things. Whereas CF, you have a diagnosis of CF before. So then you have the opportunity to look at the pancreas, and you have exocrine pancreas and the endocrine pancreas that you can follow over time and see what happens to them. And one of the things that you have that has been studied is looking at the islet function in these and also the morphology. And one of the things that you will see is that there is a decrease in the beta cells overall, and also there is actually an increase in the other cells, the alpha cells, pancreatic polypeptide cells, and the delta cells. It's slightly different than what you find in chronic pancreatitis, where you actually see a decrease in PP cells, or at least there's a dysfunction of the pancreatic polypeptide cells, which I'll come to later. So this is something that has been observed, that there is a decrease in beta cells and an increase in the other cells. So this model, is helpful to understand that the primary defect, which is ductal obstruction that is occurring, can lead to this dysfunction occurring in the islets, which are related to changes in islet composition, modest decrease in beta cells, and an increase in the other cells, other endocrine cells in the pancreas. And there's also a loss of pancreatic and islet microvasculature, autonomic nerve fibers, and intra-islet macrophages. And there is T cell infiltration is increased, and there is an increase in deposition of islet amyloid, which is well known to cause dysfunction of islets. So this is the model that you have, that when you look at the pancreas, you have the B cell, but then the ductal cells, the acinar cells, the pancreatic stellate cells, islet-associated macrophages, the microvasculature, other islet cells, and the nerve fibers, they're all regulating the islet. So for a normal functioning of the islet, you need an intact system. And when you look at, so this is a CF model. So you have, when you look at this here, you have plugging of the pancreas, you have cell death and fatty replacement of the acinar cells. There is exocrine fibrosis, pancreatic stellate cells are activated, T cells are increased, and then you have a decrease in microvasculature and islet-associated macrophages, and then you have an abnormal composition of the change in the islet cell morphology. So that actually leads to islet dysfunction in this particular system. So one of the things, we heard the excellent lecture 2 weeks ago from Dr. Kritasamy on Trikafta. So this is a study that was looking at, will a drug that is known to affect the cystic fibrosis, transmembrane conductance regulator function, will it have a beneficial effect on these islets? So this study didn't look at diabetes as such. What they were interested in was they actually looked at beta cells, islet function. So they wanted to look at beta cell function. So they took patients with CF and then who were treated with Trikafta, and they followed them. They were, and looked at the course of their blood sugars, looked at their A1C, and they also did stimulated insulin secretion, either using glucose potentiated arginine stimulation test or a mixed meal tolerance test, and looking at what are the differences that you see. So this was the overall. So they're very much the same. They had baseline thing between 2012 and 2018. They had this thing as to what was going on to them. Then they were started on treatment here, and then between 2019 and 2021 they did follow-up studies. So for these patients, the control group, they had baseline from 2012 to 2017, and they looked at what happened to them, at the time when these people were given the drug. So they had that particular information and they followed them. And what you see here is that you can see the course of their A1C, that it dropped, when they were given. So these are not diabetic. They probably is a bit pre-diabetic, but not diabetes. And then you can see that they gained weight here. The BMI went up, and of course, they showed improvement in lung function. So they did show that. And then here, this looks at different parameters of islet function. So they're looking at the glucose response, and you can see here, this is the response that you had when the patients were, there's an A that you had. So you have here, oops. So they had, lower blood glucose, whereas the control group, which is B, they were very similar. When you look at their C-peptide response, you can see that after treatment, patients who were treated with Trikafta actually had better islet function with the C-peptides. And similarly, when you look at the insulin secretory rate, that was also better when they received Trikafta versus those who did not receive any Trikafta. So what they concluded was that it was at least preserving, that it preserves beta cell function in CF through effects on glucose stimulated insulin secretion and meal related insulin secretion. So glucose, when you do arginine potentiation, it helps us distinguish between functional defects and cell numbers. So if the arginine glucose potentiated arginine stimulated insulin response is low, it usually means there is a decrease in number of islets. Whereas if you just see with glucose but not with arginine, then it indicates a functional problem, that even though the number of islets may be the same, they're not functioning properly. So this is the algorithm that we have for suspected post-pancreatitis diabetes mellitus. When you have that, then again, check for autoimmune markers, then presence of over diabetes prior to pancreatitis, and then it is this chart is very similar to the one that I previously showed you, and then again, depending on whether they are acute pancreatitis or chronic pancreatitis. So this is the algorithm that we follow for making a diagnosis of chronic pancreatitis related diabetes. So one of the other hallmarks of the condition, obviously, how do we distinguish this? Is there any other way to distinguish it? And there was some suggestion that this may be possible, but so in this study that was published last year, they showed here that these are patients with type 2 diabetes versus patients with pancreatic ductal adenocarcinoma and those with chronic pancreatitis related diabetes. And what you see is both the basal C-peptide concentration and the stimulated C-peptide concentration are much lower in patients with either pancreatic ductal adenocarcinoma or chronic pancreatitis related diabetes. So that is one of the distinguishing features that we can use when you have any doubt about whether this is type 2 diabetes or type 3C diabetes. So once you have this diagnosis, one of the things about it is, does it matter? So one of the important differences is from a management perspective is that for the management of type 3C diabetes or those sort of chronic pancreatitis, the approach to all these different things, because you'll have to address the nutrition issues. They do have malnutrition, undernutrition. So, so you have to address that, and kind of make dietary changes necessary if they're undernourished or overnourished. So, so those diets will be very different. Whether you will need to put them on supplements or, medium chain triglycerides. So those depend on whether they're able to correct their nutritional deficits or excess nutrition with initial dietary interventions. Then they will need exocrine evaluation, pancreatic exocrine insufficiency, and then replacement with pancreatic enzymes. That is critical. And then you have to do endocrine evaluation, and then treatment. So there are a range of treatments that are available for diabetes, but the only two actually have been well studied. One is metformin, the other is insulin. There are some studies with GLP-1s, particularly, not in pancreatitis, but there are small studies in CF diabetes where they have actually used GLP-1, and they did not have a problem. But I think most people would still be very hesitant to use GLP-1 or analogs in these patients, because one thing that they have shown is that in many patients with type 3C diabetes, they have defective GLP-1. So that is something that you may look at. And then you have to look at the evaluation of deficiencies, and then bone metabolism, just like you heard about in CF diabetes or CF in general. So for there's a pancreatic exocrine disease and general measures, because one of the contributors to worsening diabetes and decreasing islet function in chronic pancreatitis is smoking. So advising them about smoking cessation and alcohol abstinence. In fact, it's also important for those who have undergone islet transplantation. So the other category is the pancreatic cancer and diabetes. So we had acute pancreatitis, and you have chronic pancreatitis, and you have pancreatic cancer. So the relationship here is quite complex, because diabetes itself increases the risk of pancreatic cancer. And then on the other hand, you have this incidence of diabetes in pancreatic cancer. So we know that long-standing diabetes is established risk factor. And then, new onset diabetes as a manifestation of pancreatic ductal adenocarcinoma has been recognized over the last 10 years or so. And there are efforts to see how we can use this to improve the diagnosis of pancreatic cancer, actually. Because is this an early marker of pancreatic cancer? So, when you look at this here, this shows prevalence of diabetes in pancreatic diabetes. So if you look at here, if you have individuals with pancreatic cancer, you have a very high percentage with abnormal, only 14% have normal fasting glucose. Whereas in this controls, age-matched controls, you had 59%, and then 47% with diabetes and 7% here. And of course, impaired fasting glucose is about the same. And then when you look at new onset, the risk, 3-year incidence. So if you look at the general population over 50 years of age, this is the average risk of pancreatic cancer. Then it goes up if there is smoking, obesity, and longstanding diabetes to 1.5 to 2-fold. So if you have, family history of diabetes with pancreatic ductal adenocarcinoma, and then new onset diabetes, then it goes 6 to 8-fold. And then for those with hereditary pancreatitis and chronic pancreatitis, and there is another thing called the NPAC model of new onset diabetes. So there is a scoring system which relies on their age, gender, smoking habits, and also some genetic history. So there is a score that you can get, and that can predict the risk, and it goes up to 25 to 50-fold increase. So there's some effort to try and see if we can use these to make a diagnosis of pancreatic ductal adenocarcinoma earlier than what we have currently been able to do, because the 5-year survival rate for pancreatic cancer is like 10%. So it has a very high mortality. So one of the areas that has been worked on is to look at tumor-derived exosomes. And so these exosomes are, they're synthesized during maturation, and they are then secreted into the circulation. They can act both paracrine and endocrine matter. They can, so these things can have an impact on target cells. So there are receptors for these. Depends on what is inside these exosomes. And one of the studies that was done, there are many studies looking at different exosomes. One of them is a protein called adrenomedulin, which has been implicated with pancreatic ductal adenocarcinoma. So either you have adrenomedulin, and it's also possible that there is adrenomedulin receptor that can be there in the beta cells, which can cause a decrease in islet function and islet destruction, and also can cause increase in insulin resistance. So this is one of the mechanisms by which the diabetes may be occurring. And also it is one of the things that if we can measure in the blood, it is possible to identify. So there are ongoing studies to look at different markers that may be secreted by these pancreatic tumors. In fact, for very small localized pancreatic adenocarcinomas, where they have only removed a small portion of the pancreas. And so these are people who had pancreatic adenocarcinoma. They were diabetic, new onset diabetes. When they took this tumor out, the patient became normal glycemic. So that was one of the clues that the tumor was having a paracrine effect, or it was having. So it was not due to destruction of local destruction, but it was a systemic effect that was occurring. So it was a paraneoplastic syndrome and not direct destruction. So there are examples of these, and in some of these tumors, from these tumors were the data that showed these exosomes, with adrenomedulin in them. So this is a kind of a provocative thing that was put out, where if you have new onset diabetes of any type in individuals over the age of 60, and then, there are this classic type 2 diabetes, so for which you don't have to do anything, high risk individuals, so if you have decreased insulin secretion and insulin resistance, this is a high risk individual for development of pancreatic cancer. You might want to do MRI, EUS, and then you can, see if they have any pancreatic cancer. This one here is typical type 2 diabetes, where you don't have to do anything, okay? But if they have significant weight loss, then consider doing a CT of the pancreas. And then, of course, depending on what you find, they offer these different approaches. Then if you have, decreased insulin secretion and normal insulin sensitivity, again, they would recommend doing a transabdominal ultrasound. If there is a mass more than centimeters, then you go for multidisciplinary therapy. If the ultrasound is negative, just monitor them, And then, of course, there are these other types of diabetes. So the only problem with this approach, this is one of the suggestions that has been there, is that the cost of doing these kinds of imaging procedures for people who we consider at high risk is quite high. So because there are so many new cases of diabetes that are diagnosed every year, that and even if you take over the age of 60 years, which is the most common time when we diagnose people with diabetes. So then you have diabetes after total pancreatectomy. As I mentioned, is unique pathophysiologically, clinical features to complete loss of pancreatic parenchyma. They have more difficult to treat because of the endocrine abnormalities, and also they have weight loss. They are more sensitive to insulin because of the weight loss. Many of you have seen our patients who have undergone total pancreatectomy with or without islet transplant. You will see how much weight they lose, how sensitive they are to insulin. They have very brittle diabetes. So that's one of the things that we have to keep in mind. So, so for these reasons, one has to be very careful on how we treat them. So glycemic management after total pancreatectomy is with insulin. You do it, perioperatively with continuous, infusion, variable insulin infusion. Some people have data to show that if you do a combination of basal plus continuous variable infusion, you will get somewhat similar results. So these are tests showing here continuous, this is the dark one is the insulin infusion. The second one is basal insulin plus. So you'll find more people achieving target blood sugars, and also you actually require less insulin when you do that as opposed to just the insulin infusion. So you can see here the initial, they are on parenteral nutrition, then they go to enteral nutrition, and then they are long-term, they are on subcutaneous insulin. They require much less insulin than the average patient, even with type 1 diabetes. So this is to compare to type 1 and the pancreatectomy patients, and you can see that the basal insulin rates that they need is much lower than what is needed. This is a 24-hour period, and you can see that they need much less insulin than those with it. So this is the algorithm that you have. What are you going to do? That means for chronic pancreatitis, yes, there is a high risk of diabetes, but they also have a lot of pain. So the treatment is variable. You can do pancreatectomy, either partial or total pancreatectomy, and these are the indications. And you can see here, if you have non-dilated pancreatic duct, you can do Whipple's for head-dominant disease, diffuse disease, and a total pancreatectomy with or without islet transplantation. With islet transplant is the preferred one, because you can see from this data, this is one of the more recent data that was published. I put in here the children data for two reasons. One is this is the latest one that has been published. Second is also because children actually have better outcomes with islet autotransplantation. Either for some reasons, the islet yields are higher. They often have genetic types of pancreatitis rather than alcoholic pancreatitis. There's more fibrosis in alcoholic pancreatitis. And you can see that in general, you can get significantly better outcomes in these individuals who have had total pancreatectomy with islet autotransplantation. So you can see the time for islet graft failure. I mean, this is up to 120 months, and you still have, so the younger the child, you actually had better results. So you have almost 80% islets functioning well, whereas for the older individuals, it's around 60% or so. And then this shows you time to first off of insulin is very quick in the younger individuals than in the adolescents, and the permanent, when they have to restart insulin is also, how long it takes, So these do indicate that, with an islet transplant that you can prevent in a substantial number of these individuals. PROCEED study is one of those where we have, this is the NIH set up a consortium looking at multiple aspects of evaluation of chronic pancreatitis for epidemiologic translational studies, and they have, they are ongoing, and some of the results are coming out, looking at genetics, looking at metabolic testing, microbiome analysis, imaging. So you'll see more of these, and these are the different areas, the groups that have been looking at multiple aspects of chronic of pancreatic disease. And one of the results from this is the PREDICT T3 study, T3C study, which showed here. This is the actual flyer from that, the take-home point, where you can see here that the things that actually predict development of diabetes is the after pancreas is African American race, surgical therapy, and pancreas calcification. These are the things that have higher rates. Then you have pre-pancreatitis DM, the presence of pre-pancreatitis DM, of course, and then you have concurrent, means smoking is an important risk factor. So these are things that we have to keep in mind when we evaluate patients with pancreatitis, because if we see high risk for progression, it may be a time to actually intervene. For them, doing a pancreatectomy with islet organ transplant may actually be better than waiting for them to develop diabetes by themselves. So I'll summarize it, but if the type 3C diabetes is increasing prevalence and likely the second most cause of type 2 diabetes. If not now, it soon will be, unless we do something else. The pathogenesis is complex and varies with different causes. Some of the risk factors are the same for developing diabetes and pancreatitis. So for the exocrine pancreatic disorders, it requires a multidisciplinary team because you have endocrinology, GI, and surgery, nutrition, all working together to get these things done. And approaches to glycemic management currently, as I said, is mostly with insulin. I didn't show you all the pump studies and all these, but there are different ways of addressing this. But more studies need to be done to kind of refine what else we can do in terms of SGLT2 inhibitors and other drugs. So this is the code for today. We're happy to take any questions. Okay.
Great overview, thank you. I had a question. You showed the pancreatic cancer incidence, prevalence, and you said age over 50. So just thinking about the CF patients, because most of them, they've had it since like birth and early. Is it the duration of the pancreatitis or is it just age factor?
Well, the duration of the pancreatitis does count, but because there are not that many older patients with CF, we're not seeing. I mean, the longer they're going to live, the more Trikafta is effective. We have to see what other problem will come up. But hopefully, with drugs like that, if it does have beneficial effect on the pancreatic exocrine function, it might actually be helpful. So this question here.
talked about the GLP-1. There's some incretin studies by Andrea Kelly from UPenn.
Correct.
DPP4, but the GLP-1 is mostly case reports or animal studies. But SGLT2 is also something I was interested in. And I know you had mentioned earlier, one thing unique is there's no DKA risk as much as
Correct.
type 1, unless they are not totally out of control or something. But is there a concern for bone? Just like TZDs, I know we have occasionally used TZDs in the TPAC patients. So is there a concern for any bones or bone or weight loss in using it?
Yeah, I mean,
independent of CR.
The question about SGLT2 inhibitors, yeah, I mean, because these people have already, I mean, to make sure that they maintain hydration, that they, don't have more weight loss, because we're trying to get them to do better with their nutritional status. So that's one of the reasons why people have done mostly studies with insulin. Whether there are other benefits, because as they get older, you do the cardiorenal benefits of using SGLT2 inhibitors. That might be something that's important. And of course, if you've had a pancreatectomy, the GLP-1 shouldn't be a problem anymore.
Yes.
So
yeah, CF gastro
mhm.
folks feel like if the pancreas is already not working, GLP-1 shouldn't be a concern. The ones they're more concerned is the ones who have intact function, who are not on EPIs or exocrine or replacement. But the ones who have intact or pancreas is not working already or very lean.
Yeah.
So when you give a GLP-1, their nausea and gastroparesis that they have, which goes along with it, actually gets worse.
Yeah, I mean, there is a high prevalence of gastroparesis in patients with chronic pancreatitis. So that's another issue.
One factor, yeah. And the ones who have intact pancreas function, then we worry about the pancreatitis. So it's like
So there was one question here about age group most likely to have. I mean, most of these, I mean, it starts from the younger age group for the genetic types of pancreatitis, but most of the patients, alcohol is still the most common. So it tends to be somewhere between 25 and 60 or so that you have these acute pancreatitis episodes. Yeah. So the question about type 1 diabetes and pancreatic cancer, I have not seen anything about it. I've read about the exocrine pancreatic deficiency, but not of pancreatic cancer as such.
Dr. Lawrence had a question.
Yep.
As to how the destruction of the alpha cell affect the beta cells. Is that like to oxidation product or?
Well, so there's a direct effect of glucagon itself on the beta cells. So that's one of the things that is hypothesized. And that has to do with insulin secretion rather than with, so the previous, our hypothesis, if you remember Dr. Samuels, no, we had the thing that the flow is BAD, beta cells to alpha cells to somatostatin cells. But in a lot of studies with human pancreases, and especially with the neurotechnology, there's kind of a mixed picture, that you can actually get alpha cells, affecting beta cells through blood flow itself, So if you have fewer beta cells and more alpha cells, that could impair function of the beta cells. So that's
An interaction.
yeah. So that's the thing. And there is another thing that can happen, and that can happen within each islet and also between islets. And the other thing is there is this thing about transdifferentiation. So the initial, we thought that once the islets develop, you have so many beta cells and so many alpha cells, and that's how it will be. They either die or they stay. But this process now is that from the islet stem cells, you can get these different types of cells. And mature beta cells can actually transdifferentiate into alpha cells, and alpha cells can transdifferentiate into beta cells. So some of these processes do occur and have been, in animal models, they can be shown to be partly responsible for some of the diabetes that occurs in classic type 2 diabetes. But here also, why does the alpha cell number go up? Is it you're generating new alpha cells, or is it because some of the beta cells are becoming alpha cells? And what drives that? What is it that makes them go from one cell type to another cell type? So those are things that we don't know. But that's one of the theories that are there. Well, I mean, the diagnosis of prediabetes, whether it is type 3C or type 2 or anything, is the same. It's based on how the blood sugars are. And yes, it will go through different stages of development. It's not like over, immediately it'll go into, I mean, of course, with an episode of pancreatitis, you can be having nothing and become diabetic. But in a lot of chronic pancreatitis patients, you will see that gradual progression from normal glycemia to prediabetes to diabetes. You will see that occur. So that's one of the things where there may be an opportunity to intervene and affect the course of the disease. As to whether there are Ayurvedic drugs or other herbal medications, there are some studies on turmeric in patients with chronic pancreatitis to see if that will preserve beta cell function. But I don't think they're robust enough for us to say much about it. But certainly there are studies on the microbiome, studies on herbal, I mean, particularly turmeric, because of its anti-inflammatory properties, that it may have some beneficial effect. But at this point, there's nothing that we recommended. Okay, thank you.